Hi everyone. So glad to see y'all here. I'm Sharon. I'm a member of the H-STAT team, along with Brandon, who will also be helping to moderate today, and then Rebecca, Servi, Alice, Christina, Maddie, and then Avni will be joining us later. So H-STAT is a Georgia-wide organization focused on service, education, advocacy, and policy. And this year we started a series called Health Professionals as Policymakers. And so our talk today will be with Dr. Pullen. We're going to be talking about some health disparities, barriers to care, and interprofessional work in working with the HIV/AIDS patient population. Just a little roadmap for today. We're going to start with an intro by Dr. Pullen, just about herself and her work, and then we're going to move into a moderated Q&A. In the last 15, 20-ish minutes, we'll have an open Q&A. And so if you have any questions throughout this whole thing, you can either chat to the whole group or to either me, Brandon, or Rebecca. And during the open Q&A, y'all are also welcome to just unmute and ask your questions. And so now Brandon's going to go ahead and give us a little introduction of Dr. Pullen.
Hey everyone. Okay, so I get the pleasure of introducing Dr. Pullen. So Dr. Pullen is a physical therapist, associate professor at Emory University, and public health expert. She has worked in various settings in Atlanta, Boston, and New York City, and has performed pro bono medical and public health work in Latin America, and is in the U.S. Dr. Pullen's research focuses on chronic pain and opioid use among people with HIV and physical rehab at different stages of HIV disease. She is funded by Emory's NIH Center for AIDS Research and NIH National Institutes of Drug Abuse, or NIDA, and is a member of the Canada International HIV and Rehabilitation Research Collaborative. Her research also examines physical rehabilitation in underserved populations, namely in identifying social determinants of health and barriers to care for help disparate individuals and communities. Please, everyone, you can either clap or use the reaction to, I can't find words. Help me welcome Dr. Pullen, please.
Thanks, Brandon. And thanks you all for having me. Thank you to Sharon for reaching out in the first place. And yeah, so I'm Dr. Pullen, and you can find me in the School of Medicine building sometimes. And also, actually, my office is right in the little Zoom background. My office is right behind me. So that's where I usually am. And then where I often am also is the Grady Ponce de Leon Center, which is the AIDS clinic and through Grady here in Atlanta. And, you know, I got my doctorate in physical therapy, and I was practicing for a few years, and I realized I had one of those awful realizations like, oh my gosh, I have made a huge mistake with my life. I don't want to be doing this. I don't want to be treating preventable disease all the time or preventable injuries. And so I had a little bit of a crisis, younger than midlife crisis. And I thought, like, what should I do? And then I decided to go to get my Master of Public Health here at Rollins at Emory. So I thought, okay, let's just see if I can, kind of find my path a little bit here. And what I realized at Rollins was that I was looking at healthcare wrong. I was looking at it with like diagnosis, intervention, and treatment to the individual. But when really we have to be looking at communities, right? We have to look at where are people going home to? So if the goal is to go home, right, after the hospital or after your outpatient appointment, then what are people going home to? What community, what house situation, what food situation, what mental health, safety situation. So that started kind of steering my path a bit. I had always been interested in working with HIV from a clinical perspective because it's a moving target. It never changes, right? low back pain and rotator cuff sprains don't really change, right? They're pretty much, you learn about them once and you don't really learn much more about them after that. But with public health and HIV, it's just such a moving target. And I thought that was, really exciting. So in about, 8 years ago, I went just kind of cold called the Pont Center and said, hey, I'm a faculty at Emory and I'm really interested in physical rehab for people with HIV. And they said that there never had been physical therapy there. They have, of course, MDs, PAs, RNs, nutrition, pediatrics, but never physical therapy. And so I've been really able to find such a happy place there. In the physical therapy world, I think there was kind of a lot of like, what? PT for HIV? You just give them their antiretrovirals and then they live and then that's it. But it's really not, because it's like the chicken or the egg with HIV, right? Is it the drug? Is it the life-saving medications or the virus that's giving all these secondary impairments? And also the population at the Pont Center is over 90% racial ethnic minority, over 95% below the poverty level. So, as a patient population that even if they have back pain, it's not like, well, stretch your hamstrings, strengthen your core, and that should be it, because there are so many health disparities, social determinants of health, barriers to care, that the patient population was facing, which will inevitably affect their outcomes, right? Whether that's taking their medication every day or getting physical therapy, getting dental work, getting prenatal care. And so that is to say that, I got my clinical training and did it and felt like something didn't quite fit. And I knew I loved medicine. I loved the clinical world. So instead of just calling it quits, I thought, well, what is my passion? What do I love? What's important to me? And it ended up being public health, right? So then I kind of reshaped my career into, I'm still doing clinical PT, but for me, it's sub specialized, right? It's PT, HIV, chronic pain, opioid use. That's my research. And then I have a general PT clinic at the Pont Center every Thursday. So, that is to say, again, in the Pont Center is a really collaborative network. I was there today. I had a patient who had, a pain in his hip that I was a little concerned about. I thought there was a nodule there. So we got him downstairs to the main clinic. And so there's a real collaboration between the providers at the Pont Center, which is how I think medicine should be practiced, and everyone at the Pont Center, all of the staff, are all Emory physicians. And, for me, it felt impactful to see that the whole clinic is public health-based clinical care, right? Is public health-based medicine. And so that's where I do my research and I practice. And then at the med school, I teach the health promotion series. So your first semester, it's individual health promotion. It's again, looking at your patient as part of, what community affecting their for, what are they going home to, social determinants of health barriers. And then your last semester, I teach community health promotion, which is how to treat communities as opposed to individuals for healthcare and better health outcomes. So that's me in a nutshell. Happy to answer any questions about that, or if you guys want to just ask me some questions, I'm an open book. You can ask me anything you want.
Thank you for that intro, Dr. Pullen. Yeah, we have a lot of questions. I feel like everything that you've done is so interesting. I think I'll just start. So you talked about that you've worked with a lot of other healthcare professionals in treating patients with HIV, including introducing physical rehabilitation. How do you feel that this interprofessional work has changed how these patients are treated? How's it affected them?
I think, that it's been a game changer, with unfortunately, because most of our patients do not have insurance, maybe they have Medicaid or Medicare, but unfortunately, our patients do not generally have insurance, or none of them have private insurance, right? So things like PT could be, you know, a $35 copay, which is completely unaffordable for a lot of people, you know, and so being able to get PT, for example, if someone has a car accident or a stroke, right, or they're getting muscle wasting, or they have chronic AIDS related impairments and they can't get rehab, right? All they could really get for pain are pain medicine, right? And then they're not going down that road. So what I'm seeing right now is, you know, today, actually, I just a few hours ago when I was there, I had a meeting with a pediatrician at the Pont Center. And she said, you know, some of the kids who were perinatally infected, so in other words, born with HIV, now, you know, they're maybe teenagers and they're starting to have these health effects, chronic health effects, but they're only 14. So we talked about, well, how can I be a part of that care, right? How can I support the patients and the pediatricians? So I think, you know, I always joke that the Pont Center is like one-stop shopping, because they have a dental clinic, they have mental health, they have PT, primary care, women's health, pediatrics. And so having that kind of approach to healthcare, that having that multidisciplinary approach, reduces barriers to care, right? So if you have a patient that needs to go across town for PT, across town again for primary care, and their kid has a pediatrician appointment 2 towns over, something's going to go, right? Something's going to give. They're not going to make all those appointments in 1 week. Where if you have this collaborative care model, right, like we do at the Pont Center, it decreases barriers to care. Logistically, there's less of a hustle to get to appointment, but also it's less expensive, right? So that's not 4 different MARTA fares, or that's not paying for gas 4 times a week. So there's that. My perspective is working solely with underserved communities, right? So I always think of the finances behind it, right? But also just, you know, if you have chronic pain, are you really going to feel like going to 5 appointments, you know, even within a month? Whereas we can say, okay, it's going to be a long day for you, but here's what we've got for you today. And they can kind of hit a bunch of things at once. You know, my patients often will, with chronic pain, I work closely with their primary care doctor and with mental health, right? There's a lot of anxiety and stress and depression that can go along with chronic pain. And so I always say, you know, this is a team approach, right? So if you've lived with chronic pain for this long, you know, there's a lot of trauma behind it too, often. I was talking to a physician today who agreed with me that almost 100% of our patients have experienced some type of trauma, whether it's childhood or adult or current, ongoing. And so, you know, collaborative care means I'm treating their physiological chronic pain. I see the anxiety and the trauma they've gone through. So that's not in my wheelhouse. So let's see if we can all collaborate together, right? To give the patient the best outcomes and to make everyone's job better, right? The patient, and I always talk about sort of my triangle approach with patients, like there's me, the primary doctor, and the patient are all in a triangle, right? No one has more power, right? Everyone's leaning on each other the same amount. So a patient is equal decision maker as me or the primary physician. And that can, I think, really best be achieved with that collaborative multidisciplinary care approach.
And would you be able to elaborate a little bit on how exactly physical therapy has helped these patients with HIV?
Sure. So HIV is, you know, it's a very different disease than it was 30 or even 10 years ago, right? And now we talk about it being a chronic disease. You know, the CDC moved it to the chronic disease division a few years ago, which was like, yay, it's here, right? Because it's considered like diabetes, right? It's something you live with and you're not going to die from it as long as you take care of it, right? You will not die of HIV, of AIDS, if you're taking your medication. Life expectancy is equal right now for people who take their antiretrovirals and people who don't have HIV. So, but the difference is quality of life, right? Kind of good years, as we call them. So with physical therapy, I see my role as, well, let's increase the number of good years, right? So HIV is an inflammatory disease. And so inflammation does not just affect the immune system, right? Inflammation affects the musculoskeletal system as well, neuromuscular system. And so for example, with HIV, I see a lot of chronic musculoskeletal pain, and neuropathy is another major problem with HIV, right? So that's when there's some nerve damage. And what we think is that neuropathy is caused by actually the antiretrovirals. So what keeps you alive also makes you have these horrible like pins and needles in your feet, right? And back in the early days of HIV, when we had just, well, I wasn't around them, but when they would give AZT, which was you probably heard of it, it was like the earliest drug for HIV. And that caused this horrible neuropathy, and patients would be in wheelchairs because they couldn't walk because their feet hurt so much. So with physical therapy, neuropathy is something I can treat, right? Because PTs have been treating diabetic neuropathy for decades. And the mechanism is the same, right? Neuropathy is neuropathy, whether it's diabetic or HIV related. So I had a skill set coming into AIDS work of a certain PT knowledge and skill set that I then had to kind of translate to HIV. And chronic pain is another one, right? So the neuropathy and the chronic pain are things that I can specifically treat as a PT, but I have to know, and this is my specialization, I have to know the medications that they're on, right? I have to understand the medications that they're on. And I have to understand that, you know, with HIV, there's also a higher chance of patients getting lymphomas, a kind of cancer, right? And so if they're saying their shoulders hurt, I need to make sure I'm checking their lymph nodes as well and their armpits. You know what I mean? So I think that I can help because I'm not just kind of a Joe Schmo PT, sports medicine, you know, no offense to the sports medicine people, they've got quite a skill set, but you know what I mean? Like I have a background in HIV specifically, so I can help them through their musculoskeletal, neuromuscular issues common to HIV. I always say, you know, HIV related impairments and non-HIV related impairments, like a sprained ankle in the context of HIV disease, right? So if you have a sprained ankle, this is an example, if you have a sprained ankle with HIV, a vitamin D deficiency is very common with HIV, which can cause brittle bones, right? Osteoporosis. So if someone sprained their ankle, but they're HIV positive, I have to always be thinking, well, I know they have probably brittle bones. So let's make sure we x-ray the ankle and not just assume it's a sprain, right? So I think that's what, you know, the main things is knowing HIV common impairments, PT related, and also knowing kind of what looks like a horse might be a zebra, right? So you have to kind of see, like, dig a little bit deeper.
Okay, the next question. So continuing with the discussion, talking about multidisciplinary work, what can we as like students and later on medical professionals do to foster greater interprofessional work in all settings?
That's a great question. You know, I would say as students get as involved as you can. One example, are you guys all from school of medicine or school of nursing or kind of everywhere? Yes, and okay. Yes, and so we have the South Georgia Farm Worker Health Project. Have you guys heard of that? We didn't have it last summer for the first time in 15 years. And we're not having it this summer, unfortunately, too, because of COVID. But that's an example of interprofessional work, and I lead the PT team there. And it's out in the fields of South Georgia. It's an amazing program. And it used to be what I call like a silo approach, right? Like, you know, in farms are the silos full of grain. And it's really, they're separate, right? They each have their own grain inside of them. But what then happens is that patients get that silo approach, right? So at farm workers, what we were seeing is that patients would basically go to, go to the physician and the PA or nursing students, and then they would get that care, and they would go to the PT tent, and we would be like repeating the whole subjective exam, right? That they would have to sit twice, and probably repeating some physical exams. So we realized a couple of years ago, well, hey, let's do this collaboratively. So now there's the farm worker goes with a PT and a PA or MD student, and then they do a collaborative patient treatment, right? So one example is, this is how you all, whatever your fields are, can be helpful. So like, one example is there was a farm worker who said he had really bad chest pain. And so of course, what do you think of the first thing you hear chest pain? What immediately comes to mind to rule out? Heart, right? Cardiac. So the PT student sat back a little. The MD student did a cardiac exam, workup, and there are preceptors, so PT, MD, PA faculty, so you're not on your own there. And so cardiac was normal, and the PT student said, well, what crops do you pick? And the gentleman said, I pick grapes. And the PT student said, well, can you show me what you do? And the farm worker was doing this motion. So the PT student palpated, and it was the pec minor muscle. That's that tendon you can kind of like poke around here. It hurts when you push on it. And so it was a pec minor strain. Very easy to fix, right? You just put your arm on a door frame and turn away from it, and you stretch it out. So it's like bada bang, bada bam, super easy to fix, right? Definitely easier than a heart attack to fix. And the MD student was like, what? I would have never thought to ask him what he picked or how he picked it. And the PT student was like, whoa, I would have never known how to do that detailed of a cardiac workup. So, but then next time that PT student saw someone with, chest pain, they're going to know a little more, right? And as a PA or MD student, they'll know to not just be tunnel visioned on cardiac. They'll think, oh, well, what kind of musculoskeletal issues could there be working with us? So I think that that's important for students. So the farm worker program is not happening this summer, unfortunately. I'm hoping we can pull something together for the fall. I know it's horrible, but I'm hoping we can pull it together for the fall. And then, so there's a pro bono clinic, which is in Good Samaritan Clinic. Do you guys know about that? And PT is going to start back up again in the fall there. And so for me, it's, for me personally, I think like, well, again, I don't want those silos. Like they're exam rooms. They're not farm worker tents now, but they're like, personally, I don't think students should be in exam room separately. Like, I think that we should still collaborate, right? If it's something that's clearly just PT or clearly just, whatever the case may be, I think that's one thing, but I think that there's so much to be learned from working together, right? As interprofessional. And so as a student, I would say really look for those opportunities, especially with like service learning and volunteer work. And then when you're on your clinicals, just see, can I shadow a physician, right? I will say that at the Pont Center, I've learned so much about general medicine and infectious disease, right? I give in-services to the staff often and teach them how to like rule out a rotator cuff tear versus a sprain. A tear, if it's a tear, you need to get them an MRI. If it's a sprain, just tape it or send them to me. I'll tape it. It'll take 5 seconds. Right. And so I think that that's it. It's that. And it's also, I think just being open to learning. Like none of us know everything. I definitely don't. And so I think it's, really just kind of being open to learning. I can't remember if I told you this in my bio, but I do a lot of work in Dominican Republic. And so I take a group of PT students every year. I didn't last year, sadly, but every year to Dominican Republic. It's a rural town, and we spend a week like blood, sweat, and tears working like sun up to way past sundown. And we've been going there for 9 years. And it's life-changing and life-affirming and career-affirming, I think, to the students who go. And so I'm like, oh my gosh, what if we could collaborate, right? Like have nursing students come with us or have med students or PA students. So I think that like the more community work, and this is my public health hat that I'm wearing right now, but the more community work that we can do interprofessionally, it's better for the patients, right? Because they don't have to sit through, tell their medical history again, you know, for the second time in an hour. And I think it's good for, it defers to the patient, it respects the patient's time. And it's better for students to learn from each other. So that's my long answer to that question.
Thank you. Do you have any tips for how we can build those interprofessional relationships in places that don't have that established yet?
So were you talking like the workplace or school or kind of?
I guess I'm thinking more like once we start working, how we would start to like foster that kind of interprofessional work.
Yeah, so I would say like in hospitals or bigger clinics, that's a little easier because you've got staff PTs, you've got staff nurses, you know what I mean? Staff nutritionists. So, you know, for my chronic pain patients, I'm like, well, you're eating a ton of salt every day, right? You're never drinking water. So like, I don't want to go out of my lane nutritionally because I only know so much. So that's when I pull in nutrition. So I think that's that kind of thing, like to say, hey, can we, you know, can I you know, collaborate with this person down the hall? Another thing is that I'm really a big fan of grand rounds, right? Even informally. So I'm a big fan of saying, you know, okay, can we set something up where we can present cases, right? So like I could present a case to you all right now and you'd all have something totally different probably to contribute, right? Even if you're in the same program, you'd probably have totally different things to contribute. So I think that one, it could be, you know, a current case, right? Like, all right, I've got this case, this, and this, what's everyone's input? Like that's how medicine should be practiced, right? You should do, I think people should do rounds once a week, at least, challenging patients, or just to say, make it a learning experience, like prepare a case, right? And say, here's what I did with this patient. I'm wondering what I could have done better. I'm wondering if the nutritionist has anything to add, or PT or OT, or you know, depending on how many disciplines there are there, right? So it could either be a current case or like a past case, like a case study. But I think that actual real patient cases, it's like whenever I try to, for classes here at the med school, try to make up cases, I always like go into this weird stratosphere of like making up these weird details. And I'm like, I have a million actual people I could pull from, obviously not with their names, but it's like, you can't make up this stuff, you know, that patients have. So I think it's like saying, hey, can we all get together? And if that's like not part of, if it's like, no, we can't with scheduling or shift changes, then I'm a fan of saying like, well, who's interested in starting like a case club, right? When you say journal club, people kind of are like, nah, I don't want to read journals. I mean, I like journal clubs, but they sound boring, frankly. So what if you just were like, hey, I'm interested in starting a case club, you know, over lunch every Friday or something, right? We all meet up, someone brings cookies on a rotating basis, you know, so things that make it attractive, right? That people would want to talk about, because I know for me, like I can't imagine not practicing at the Punt Center or at a collaborative place because I don't know a lot. There are some things that I could be missing, right? I found out today that this guy that had this kind of nodule in his inguinal like groin area, that could be a sign of an STI. And I had no idea, right? So that was something I learned today. Like, oh, I was thinking, you know, he had pulled his iliopsoas, or he had like got, you know, a musculoskeletal thing or a hernia, but I didn't know that infectious disease part of it. So, you know, I think that is something to really to think about for sure.
Yeah, that's definitely not something that I would have thought of. So thanks for that idea. And so beyond interprofessional collaboration. What else can we do as medical professionals to break down those barriers to care, and how do we foster trust with the community?
Oh, that's such a great and a big question. Say it again so I make sure I get all of it.
So what can medical professionals do to break down barriers to care, and how do we foster trust with communities?
I would say to break down barriers of care, you know, I always say in class, like the Hippocratic Oath is what? Do no harm, right? That's what you sign off on, right? We've all signed up, or you will sign off on it. We all sign off on it. We get our license and we sign off on it, do no harm. But to me, we have to think about what that means. You know, back in the day of Hippocrates, it meant like, don't hurt people or kill people as a medical provider, right? Like it's your job to make them better or to save their life. And I see it as like, well, there's so many ways of doing harm, right? Whether it's like microaggressions, macroaggressions, assumptions about people, right? And so I think breaking down barriers to care and establishing trust are kind of the same thing, right? So again, so for me, I did telehealth for 9 months this in 2020 because we had to. And I realized, wow, there's no problem with people not showing up to their appointments because they don't have to go anywhere. They don't have to spend money to drive anywhere. They don't have to get childcare. So for me, I changed my practice because I realized that in-person visits can be a barrier to care, right? Whereas I've been practicing for 15 years and I never once thought that could be a way to reduce barriers to care. And so now, you know, I mean, don't get me wrong, doing PT over telehealth has its definite drawbacks. I was like reaching towards the camera and I'm like, oh wait, no, sorry, I can't palpate them. Sorry. You know, so awkward. And so now I say to my patients, you know, they come in for the first visit. When I talk to them on the phone to set up the appointment, I say, you know, I'd like to see you in person for the first visit, but if it feels like too much of a burden to come in person every week, then we can definitely do it over video call or phone. So I kind of set that up for them right away, right? And I don't say like, if you can't afford it, but I just say like, hey, if it feels like too much of a burden or if it just doesn't work, then we can totally do it. So in other words, like I want to retain my patients so they'll get better on their terms, right? Retain them on their terms. So I think that's one barrier to care. That's a very specific answer about it. But again, just reducing those barriers, right? Whether it's, you know, transportation or childcare, right? I'm like, bring the baby, bring the kid. Just we've got books here, we got kids' books here. You know, you don't have to get childcare. I don't mind if the kids are allowed, right? So everything you can do to reduce barriers to care for them. And you can ask, you know, will you be able to come to your appointment? If they say no, you can dig a little like, oh, anything I can help with, right? And if it's childcare or if it's transportation or whatever the case may be. And I will say, if they're like, my car is, you know, not working or I don't have any money even to get there, and you have to see them in person, your organization might very well have some kind of a little fund, right? Oh yeah, we have a stack of MARTA cards, or yeah, we can call them a cab, right? You know, you can ask your front desk, ask your social worker at the clinic, you know, do they have any options? And I think for me, in terms of establishing trust, you know, I work with mostly with chronic pain. And so one thing people, I mean, almost every patient that I say, how long have you had your pain, is they'll start off by saying, well, you're not going to believe this, or nobody believes me. Isn't that sad? And I just, my heart like gets a little crack in it every time I say that, because then I say to them, I already believe you. I already believe you. Just because we're sitting down, I already believe you, whatever you're going to tell me. And you know, often it's 30 years, 20 years, and it's from trauma. They had a trauma 30 years ago and they hold it in their neck, you know, or they're holding it in their back or their shoulder or their abdomen. And so also patients will say, okay, well, this is kind of gross or this is kind of scary. And I always say, whatever you're about to tell me, I've heard worse. Trust me, I've heard some things, you know, kind of like make a joke about it. Like, I feel like people can be embarrassed to tell you something, whether it's like, about sexual health or about pelvic health, whatever you're about to tell me, I've heard more graphic, you know? And so that puts them at ease. And they're like, okay, like this is not the worst thing she's ever heard. And maybe it is like the most graphic I've ever heard, but I don't tell them that. I'm like, oh, okay, yeah, cool. Okay, let's talk about this, you know? So, you know, I think there's that. And also I never make assumptions. So, you know, if someone, I use the word partner always instead of husband or wife or boyfriend or girlfriend or anything, you know. One thing I do, this is things I've never learned in school, but I'm trying to think what I do to put these, you know, gain trust. Like I always ask people if they live by themselves instead of who do you live with, because you never know people's situations, right? They could have been with a bad situation before, who knows? So I always almost like start with, so do you live by yourself? And then if they do, they're like, oh, that's the norm here. Yes, I do. Or they're like, no, I live with my partner. I live with my sister or my mom or whatever, you know? So it's almost like I start at zero, right? I use gender neutral pronouns for, do you have a partner, right? A significant other? Do you live by yourself? So I almost feel like I have to check all my assumptions before I ask them anything about their social history, you know, or medical history. And I guess for me, you know, that is, that's a short answer. I don't know if you guys have a whole lineup for your series, but I have a whole lecture that I give to the third years about barriers to care and implicit bias. And so I'm happy to come back another time. It'll be, you know, it's somewhere in my hard drive here, but and we talk really specifically about like, what can I as a licensed medical professional do to reduce barriers to care and to check my implicit bias, because we all have it, unfortunately.
Kind of going off of that, how can we kind of speak to the community and kind of promote coming in or doing telehealth or whatnot with medical professionals? Because representation is a huge factor, and it could be a barrier to care, of just like seeing people that look like them in the medical profession. Like, how can we show the community that there is diversity within the medical profession, and like, how would we go about having some type of event or whatnot to speak to said people that are either afraid or kind of like hateful towards medical care because of previous experiences or family experiences, or bouts of discrimination and whatnot?
Absolutely. I mean, I'm June 8th is my first class for the individual health promotion, and the first class, the first half of it, I talk about Tuskegee. I show them a really disturbing video about it to get their attention, you know, and then I'm like, this is what you're walking into. This is what you're walking into. Now I can talk about, you know, COVID vaccine hesitancy among underrepresented minorities. Like, yeah, the government sticking the needle in my arm. I could see it. I have patients who are direct descendants of sharecroppers who were in Tuskegee here in Atlanta. So like, you know what I mean? Like, I think that that's a huge thing. And to say there is representation, I mean, I think that, you know, depending on where you work, you know, get yourself out there, right? Whether it's on the media or on flyers, you know, I mean, I think it's important to have photos, you know, whether it's on a website, you know, please meet our team, have photos up there, right? I think that's really important. I also think, I mean, again, this is my public community health hat I'm always wearing. And to me, I just feel like just get out there. I run the service learning program for our department. And so we do the Hispanic Health Fair. Have you guys heard of that? The Feria Latina de Salud. That's every October. It was not in 2020. A huge event. It's, I know, I miss it. And it's for the Latina community here. And it's I mean, hundreds of patients come, and there's it's at a big church on Buford Highway with a huge parking lot. you know that it's like a Catholic church with like, it's like a whole compound. So it's awesome because there's indoors and outdoors. And it's almost like farm workers light, right? They're not migrant farm workers, but a Spanish speaking community. It's on a Saturday because, so people who work don't have, can come. Pediatrics there's a mammogram van, there's a dental van, there's flu shots, HIV tests, PT. So that's something that, it's obviously, it's all, Latino communities who come. And to me, that's also, it's free, of course, so it's like, to me, it's just that. It's like, my mantra is like, if you know CPR and you see someone choking in a restaurant, you can't be like, oh, I'm enjoying my dinner. I'm going to just let them work that out, right? You can't do that. If you have a medical license or medical training, you can't not use your tools to help people who are in need. And people who are in need are often poor people in minority communities, LGBTQ people. So to me, I get fired up talking about this because I feel like as people with a medical license and medical training, like that's our CPR. And just because someone's not grabbing their throat choking in a restaurant doesn't mean they're not in need or need to be helped, right? So it's like, for me, I feel like I will always volunteer my time because I've been given these tools, right? And I'm not just gonna sit back and be like, oh, cool, like, yeah, I could help, I could do this, but I wanna do this instead. That's why I feel really passionately about community health. So if you're at a clinic next year, a hospital, see what's going on with the community, right? I mean, when I first got to Emory, kind of pounded the pavement and looked for all these health fairs or what, and be like, hey, do you have PT? No? Okay, can we come? I got my own table. We got our folding tables. Like, can we come? And so kind of like depending on what, like what programs you're in, I mean, everyone needs nurses. Are any of you nursing students? Just nurses are always in demand, but when they find out there's things like PT or, whatever, PA, and, people are going to be like, oh yeah, we need you too. So, looking for what's in the community already, or say, hey, can we set something up in the community where we do blood pressure checks, right? A park day, do blood pressure checks. You'll always be surprised at how local businesses who will give you food for events. I've never been disappointed. So, you go to Kroger, you go to Publix, you go to, whatever, and you say, hey, I'm doing this health fair. Also, when we go to Dominican Republic, we Target and Walmart. I mean, I know Walmart has its corporate issues, but like, hey, they got a lot of this, So Target and Walmart, for example, always will, give us donations because it also looks good for them. They can say, we donated to this, international health thing, or we donated to this health fair. So, going to places, some, if you're lucky, you'll get canes and, knee braces for PTs, but food, right? Go to Publix and say, hey, could you donate? Often it's like, yeah, you can have like 5 watermelons. Great. So that morning, have a team come cutting them up, putting them on plates, right? Yeah, you can have, these breads and peanut butter and jelly and grapes. So like, you know what I mean? Like, have food and people will come. So if you can say, look, we're having a health fair, blood pressure checks, here's a little PT station. Who has low back pain? Like every adult has low back pain. Okay, great. So here's the station here. Yeah, right? I mean, I know it's like, gosh, you turn like 25 and things start to go. But like, okay, here's a station for low back pain. No one needs to get undressed or lay on a table, a PT table. Here's some basic stretches for low back pain. If you have low back pain, you probably have tight hamstrings, right? You probably have a tight lower back. Here's 3 stretches too. Here's our handout. It just has pictures. There's no language. So that reduce language barriers, just have pictures on your handouts. So I feel like, you can go into any community. If there's not something set up already, set something up, right? Go to Parks and Rec and say, hey, can we, what would be the procedure for using this pavilion for like a health day on Saturday, June, whatever, right? Cool. Okay. We don't have to have a permit. Okay. Next we go to Kroger and say, hey, what could you donate, right? We'll put the Kroger sign up, right? We will say, thank you to Kroger for your donations, right? So there's like a I'll hold your hand, you hold mine kind of thing when you do community health work, right? We're saying like, isn't Kroger so generous, right? And meanwhile, your patients get fed.
Okay. Thank you for all those responses. So now we're going to open up the floor to everyone else in the chat, and y'all can either send the questions to us or you can just say it aloud here. But now we're going to have an open discussion. So anyone feel free to ask questions to Dr. Pullen.
Hi, can you hear me?
Hey, yes.
Hi. Thank you so much for speaking with us today, Dr. Pullen. My name is Serby. I'm a med student, and I'm also part of H-STAT. Oh, I've just been pinned. I just really enjoyed hearing you speak today. And I don't know if this is a fair question, but I'm going to ask it anyway. So you specialize in HIV/AIDS, which is a field of study that's drastically changed over the last decade or two, and you mentioned that multiple times during the talk. I often speak to older providers who say like, oh, I didn't know this about HIV, or when I was being trained, this is what we knew about HIV. And we're all students about to start our health, care professions. And I'm wondering, like, what is one thing that we should know about HIV and AIDS that should be a starting point for our understanding of it that may not have been true for people who trained 5, 10, 15 years ago?
That is such a great question. I love that question. Thank you for asking it. It's really, I would say HIV is a chronic disease, right? If you take your antiretroviral medicine, you will not die of AIDS. But again, there are impairments related to antiretrovirals or the virus, right? So it's people who are living very differently than they were, but HIV disproportionately affects African Americans, right? Gay and bisexual African American men in the South, the Deep South, have a 1 in 2 chance of getting HIV in their lifetime. I mean, half of all bisexual, gay, Black men in the South will get HIV just because of those demographics, right? And so that's a huge problem. It's major. So HIV is not just an infectious disease, right? It's a social disease, right? And I don't mean like how that used to be said, like in a homophobic way, like it's a social problem, but it's become, and that's what we're seeing with, oh, don't get me started. That's what they're saying. That's what we're seeing with COVID-19, right? It's the dust is settling like it did with HIV in poor Black and brown communities, right? That's what happens. That the winds will blow any disease into Black and brown poor communities who do not have the resources to push it back out again, right? So I would say that HIV shouldn't just be looked at as like medication. It should be looked at as a public health issue as much as an infectious disease issue.
Thank you so much.
Sure.
I have a question to follow up on what you were just talking about, just like the rates of new cases in the South. So, I mean, I think I read somewhere that Atlanta is just a hot spot for new cases. And it's, I was wondering if there are any policy gaps or public health funding gaps that are driving this, because, we have the CDC next door, we have Emory here. So why is this still happening?
There's no excuse for it. It's poverty. It's poverty. I'll tell you what it is. It's poverty, structuralized racism, and homophobia. I will tell you with full confidence that is why. I moved here from Boston 15 years ago thinking like, I'm going to stay here just for, school. And then we were going to go back to Boston, and I moved to Atlanta, and we were like, whoa, we're going to stay in Atlanta because of the diversity and because of Emory and CDC. But Atlanta is I think #1 now in new HIV infections. Atlanta, Miami, New Orleans, DC, kind of I'll toss the hot potato back and forth for, for highest rates. Atlanta, I will say it's those things, right? It's poverty, it's access to care, it's barriers to care. It's not genetic. There's no genetic predisposition about being, men having sex with other men or African-American or living in the South. Obviously, there's no genetic predisposition to HIV or COVID-19, but that's why. It's because of, we can blame Tuskegee, we can blame slavery, there are historical and current reasons for it, right? And the playing field is just not equal, right? The playing field is not equal when you get HIV in Boston or San Francisco and when you get it in Atlanta in terms of access to care. And so that's why there's no stronger HIV variants here or anything like that, right? It's a non-medical reason. It's purely, again, social public health reason, unfortunately.
And to continue along that line, and so H-STAT, our organization, we're dedicated to advocacy, education, and service. And so from an advocacy point of view, is there something that you think we can do to address these social determinants of health? Is it passing more funding for public health interventions? Is it, expanding insurance access? Like what are the kind of top 3 things, or maybe number 1 thing that comes to your mind when you think of like a policy change that we should be advocating for that would help your patients?
Yeah, I think so. If you are an attorney, you have to have a certain amount of pro bono work for like, I don't know if it's license renewal, but like, to maintain your licensure as an attorney, right? You have to have a certain amount of hours of pro bono legal work, legal aid, right? That should be the same for medical providers, right? I think that if you want to keep renewing your license, it shouldn't be about taking boards. It shouldn't be about just sending in your fees. It should be, you have to say, I have done X amount of hours of community work, unpaid volunteer community work, right? Or even if you get paid for it, the patients don't have to pay. Pro bono, right? That's, I guess. So pro bono and volunteer are a little bit different, but pro bono, I would say. I also think in your training, I did like the medical Spanish elective and the MD program, which I don't know if it even still goes. I couldn't keep doing it for scheduling reasons, but I don't know if you guys have this kind of training, like specifically coursework about barriers to care, health disparities. I teach the 3rd-year DPT students this course, but I think it needs to be part of everyone's training, right? So you're going into the field with a toolkit, right? Of like, oh, here's how I can personally reduce barriers to care in my own one-on-one patient interactions, and as part of my organization, and as part of like the medical industrial complex, so I think it has to be part of training. And I think that there should be laws passed that any medical licensure, to renew it, you have to do some kind of pro bono work. And I think that hospitals and clinics could, in my perfect world, be a part of that, right? Okay, Brandon, you have this Saturday, you need to spend 8 hours doing this in this predetermined, pro bono care work, or do something on your own, or else like that's part of the job, right? Or the American Medical Association won't sign off on your license. Like, I think that should be part of all of our work.
Okay. Going back to a little bit about talking about HIV and then also talking about COVID, that we've definitely seen a difference between like COVID vaccine. We had a very quick, like we were able to develop it versus the very slow development of a vaccine for HIV.
Yes.
Have you heard this from patients who are frustrated? Why you think there's this big contrast in this timing?
Oh, I wish you guys were all in my class, because I talk about this exact thing of the HIV vaccine versus the COVID vaccine. We should talk offline about this. because I would love to be able to talk to the med students about this too, because yeah, I mean, that's why, right? So in a quick nutshell, you know, when HIV first came out, right? Do you guys know the history of HIV with Legionnaires disease and that whole story? I'll be real fast about this. So in the late 70s, right, there was the American Legion, you know, they it's white businessmen. They had a conference and there was a buffet and there was something funky in the buffet and they all got really sick and it was something in the air ducts and everyone got sick. And within hours, the CDC was there. Within days, it was diagnosed. It was called Legionnaires Disease after the American Legion members. They knew how to treat it. And you will never see a patient with Legionnaires disease as practitioners. So it was done. It was like rushed to the scene. So a couple years later, HIV started coming onto the scene and it was called GRID, gay-related immune deficiency, for years. And then it took decades, right? 1981 was the first report of HIV. 1997 was when the triple cocktail was finally invented. So, you know, if you think about white businessmen, right, versus mostly gay men or IV drug users, so there was a societal sympathy there. COVID-19, who were the first people dying? Grandma in the nursing home, right? Old people in nursing homes were the first people that were dying here in this country, right? And so there was a lot of societal sympathy for that. A lot of like, oh gosh, these poor, you know, and I mean, I have had friends who lost parents in the past year of COVID and it was devastating. I feel so horrible for that, but there was this real societal sympathy, right? It could affect anybody. It can only affect gay men and IV drug users, which of course we know now isn't the case, but then that's who we were seeing. So that's why the president then was Ronald Reagan, who he was very conservative, did not have a priority for public health, as he made gay jokes, homophobic jokes at press conferences about AIDS. You know, so there was the amount of societal sympathy for COVID and Legionnaires disease, which again, you'll maybe hear about this once on this call and then you'll never hear about it again. But that's why, I mean, HIV has been allowed to proliferate and mutate over 30 years, right? So it's a moving target to develop a vaccine at this point for HIV. Whereas with COVID, we didn't really have many variants by the time we had a vaccine. So, you know, I think that the science could have been there with HIV, right? So if you also think about, there wasn't NIH funding for an HIV vaccine the way there was for the COVID vaccine, right? So there wasn't money and there wasn't sympathy, I think, for HIV.
Okay. So I know Stefano has a question, but it is 7. So Dr. Pullen, if you're okay for staying a little longer.
Yeah.
For him, and then anyone else, if you need to go, you're free to go. I want to respect your time, but Stephanie, you can go ahead and ask your question.
Yeah. Okay, I can look through the farm. Stefano, I know it's one of the things that drew me to Emory too, the farm workers program. It really stinks that we can't go, but hopefully maybe this fall we can work something out. PT students are going to start up in the fall at the pro bono clinic. We used to go every week. If you've just started the PT program, you wouldn't know that because we didn't go last year at all. Not every week. We'll go once a month, one Saturday a month to PT, to the pro bono clinic starting in the fall. Let's see. So yeah, I am going to say a couple things quickly before we go, which is that this has been so great. So thank you so much. You know, Sharon, thank you for reaching out, and I really appreciate everyone's time and everyone's amazing questions. So thank you to everyone for that. And I know you're going to all do great things. I'm happy to, if you can think of anything else that I said that you want to expand upon, I'm happy to do more of that, more of these, if that feels helpful to you. I'm happy to, you know, I think personally, even though, you know, most of us are vaccinated, I'm guessing by now. I still think we need to lay low for the summer. Again, public health wise, I really think people need to still lay low during the summer, because the mask thing, taking off your masks, I feel like it's a little early to be living our best lives out in public right now. So the fall, for those of you who are either going to be here in the fall as students or will be in Atlanta in the fall as residents or practicing, let's stay in touch, because I got my engine's full of gas in terms of doing the pro bono and the health fairs and everything. So, and I would love, as someone said, a cookie case club sounds fun. Let's do it, right? We can totally do it. We can do it over Zoom, right? We can do it as part of, I don't mean to micromanage this, but I'm happy to help out with that or get you guys started with that. We can do it over Zoom or once, in the fall, kind of do it in person. But I think that's how we start to learn from each other, right? And we come with kind of open minds, open hearts, no egos. Yeah, tell me, show me. I would love to learn. I've got lots to learn too. So I think just to kind of keep the fires burning. And in terms of, hopefully, I've given you some ideas about volunteering and barriers to care. But if you think of anything, some of you, I know Sharon, you have my email, so go ahead and send that out. I'm happy to talk to anyone on the phone or email questions. I'm definitely back in action in person in the fall. I think that seems like a safe time for us to kind of get out into the community again. And yeah, any last questions or comments, concerns? Yes.
Well, first of all, thank you so much. Just to kind of reemphasize, as everyone else has said, it's been really awesome hearing your perspective on these things, and also love the questions that were asked. I wanted to wait until the end just because I wanted to hear everyone's questions, but also I think it's more important to ask the questions pertaining to the patients, right? And communities and all that stuff. But one thing that I kind of have thought about and I wanted to hear your perspective on, especially kind of hearing your story as to how you kind of went the route you went. I've thought to myself, ever since I knew I was going to do PT, kind of what I want most is to kind of have a broad reach, right? And not only a broad reach, but to those communities that need it most. Because I'm from Miami, and I've worked in a variety of different settings and volunteered in a variety of different settings. And I noticed that, sorry, let me get to the question. Basically just, when it gets to the point where I graduate and I'm a PT, what are maybe some advice you have for a new grad in terms of, or I guess just throughout our profession, in terms of kind of balancing, pro bono work, service, all that stuff that unfortunately, or at least from what I've been told a lot, is not very profitable. So it's kind of hard to make a living off of if you exclusively dedicate yourself to that, although it's not impossible. Just kind of so basically, how do you balance that and your involvement in that with also maybe pursuing other things that you're interested in within your profession, and that might be more lucrative, I guess. I don't know if yeah.
That's a great question, Stefano. It's great to see you. And I was going to say in person, but we're not really in person. I think that if you feel like you're spinning your wheels somewhere, then move along, right? This is not to trash talk Emory Clinic at all, which is right behind me in this picture, I know. But, when I was practicing there, I asked, well, could we do I'm usually not here on Fridays. So can I have some space here on Fridays? It's a slow day at the PT clinic. Can I do pro bono work here? And the answer was no. And I kept asking, well, I'll be here. I'm licensed. I'll be here. If I can just, can I just have one PT plinth, one PT bed for, and they were like, no. So I was like, okay. And I moved along. Right. So I would say that first. And then also, you definitely want to make sure you're not burning yourself out. If you give yourself at least one day a month, if you're the first Saturday of the month, I'm going to establish myself somewhere. People will be thrilled if you can give any kind of pro bono work, right? If there's a pro bono clinic, hey, can I come once a month here, right? Get some of your colleagues to do it too. So if you can kind of give yourself, I know for me, if I don't have it in my calendar, then it's real easy for me to be like, you know, so have it be like the first Saturday of the month is when I do this, right? And then it could be, that's just kind of part of your life, right? I would also say, you know, yeah, I think that's those two things. If you feel like you're spinning your wheels, move it along to somewhere else, because, you know, people would be thrilled to have you, right? PT is like the golden ticket for pro bono healthcare, because no one has it, right? No one has it. Fair, think about fairs, pro bono work, homeless health vans, no one has PT. So if you say, hey, I'm a PT and I'm want to volunteer my time, you'll get snatched right up.
All right. Well, thank you so much, Dr. Pullen. This is great, and just talking to you and learning more about all this knowledge you have. And thank you, everyone, for being here and for staying a little later. I put Dr. Pullen's email in the chat if you want to reach out to her individually if you have any more questions. But that's all we have for today.
Great. Thanks so much, everybody. Be in touch if you want me to, you know, if anything else you feel like I could be helpful with, please let me know, okay? You're all going to do great things. I just know it. Thanks so much, guys. Thanks for already being committed to this.